two investigators compared clinical outcomes of fractional flow reserve-guided PCI versus medical therapy alone in patients with stable coronary artery disease, an indication for which PCI has not been shown to improve prognosis. 1,220 stable CAD patients scheduled for 1, 2, or 3 vessel DES PCI were enrolled. Fractional flow reserve was measured in all target lesions. If FFR stenosis was below 0.8, the patient was randomized to PCI plus medical therapy or medical therapy alone. If FFR was above 0.8, the patient was assigned to a parallel medical therapy alone registry.
First, in the patients of the registry, the patients without ischemia, clinical event rate is very low under medical therapy. Excellent clinical outcomes in these patients, no need for PCI. In contrast, in patients with ischemic lesions, there is a clear difference. Patients treated with medical therapy alone have a significantly higher rate of urgent revascularizations and thus of primary outcome in this study as compared to the patients randomized to receive PCI plus medical therapy.
For patients taking oral anticoagulant drugs for atrial fibrillation or a mechanical valve who require coronary stenting, the optimal antithrombotic treatment has not been known. In the WOEST trial, 573 patients who were already receiving oral anticoagulants and undergoing coronary stenting were randomized to either additional clopidogrel only or clopidogrel and aspirin on top of oral anticoagulant thrombotic.
The main result of our study is that the primary endpoint was met. Oral anticoagulants plus clopidogrel causes less bleeding than triple antithrombotic therapy. Also, the secondary endpoint was met. With double therapy, there is no excess of thrombotic and thromboembolic events. And finally, with double therapy, there is even a lower rate of all-cause mortality. And therefore, we propose a strategy of oral anticoagulants plus clopidogrel to be applied in this high-risk group of patients on oral anticoagulants when undergoing a PCI.
The atrial fibrillation ablation pilot study has provided the first systematic, prospectively collected data on the characteristics of patients undergoing the atrial fibrillation ablation, the procedures around the actual ablation, and the outcomes in a real-life setting. It shows that the success is slightly lower than in controlled trials, but it's still encouraging, and there are areas where we could improve in the management of these patients, which is in the assessment of recurrences and the treatment, especially the anticoagulation treatment during the follow-up.
Reducing hospitalization for heart failure is a key therapeutic goal in order to decrease heart failure-related mortality. During an ESC 2012 clinical trials update session, Jeffrey Borer presented data on the rate of hospitalization for heart failure in 6,505 heart failure patients enrolled in the SHIFT trial who were treated with ivabradine or placebo on top of optimal medical therapy.
The result of the analysis showed that in terms of total heart failure hospitalizations throughout the trial, treatment with ivabradine resulted in 25% fewer heart failure hospitalizations than treatment with placebo. This was a highly statistically significant result. In addition, using the total time approach, the time to recurrence of heart failure hospitalization was significantly longer with ivabradine than with placebo.
I hope you have enjoyed ESC 2012, which was a great success. We are looking onward to welcome you in Amsterdam next year, August 31st. We're expecting a great success also there.